Now, usually the questions in trauma is EDH versus SDH. One important thing you need to understand in EDH, it is going to be an arterial bleed. SDH is going to be your venous bleed, right? It's a collection of blood between dura and the skull bone. Here it is between the dura and the arachnoid membrane. It is usually because of temporal fracture causing pterion injury. Here it is elderly patient with hit, blow, or any component injury to the head per se. The most common source of bleeding is middle meningeal artery for your extradural. This is your cortical bridging veins. Remember, in both the conditions there will be increase in intracranial pressure, but in EDH there is sudden increase, whereas here it is going to be gradual increase in intracranial pressure, right? Now, one of the most important is presence of lucid interval, the characteristic feature. Here it is going to be fixed dilated pupil. Investigation of choice, both the conditions is NCCT. Here you will see a biconvex opacity. A biconvex opacity, which is also called as the lenticular opacity. This is what called as concavo-convex opacity. Here it is called as the concavo-convex opacity and also known as the crescent opacity. Management here is going to be craniotomy, whereas SDH, if it is large, then only craniotomy. Small SDH is conservative. For chronic SDH, we do burr hole surgery, and that too, we call it as chronic SDH as chronic if the SDH persists for more than 21 days.